that way?
Absolutely.
Okay.
So let's pretend for a minute that we're in front of 100 people at the First Presbyterian Church at a Rotary luncheon. And so, ladies and gentlemen, we have with us three distinguished doctors from Worcester, Dr. Tony Tizzano, Dr. Adam Keating, and Dr. Diedre McIntosh. And they are going to talk to us about telehealth and how they call it e-health or mobile health or telehealth, where this whole new way of providing medicine is going and where it's taking us. So I will turn over first to Dr. Tony Tizzano.
Good afternoon, everyone. Thank you very much for having us. This is kind of an evolving topic, and I think it would be interesting to kind of share some of our thoughts and perhaps dispel some of the misconceptions surrounding telemedicine. Certainly, this is not new. And in fact, in the Cleveland Clinic system, we've been doing this one way or another for many years. But the environment we find ourselves in now with COVID has certainly thrown gas on the fire, and all of a sudden we found ourselves out of necessity having to expand what we were doing. And for some of us, perhaps it's the only way that we were communicating with patients. So I think this is going to be a wave of the future. Many people would say, well, gee, we really don't want that. That's not how we want to engage with our healthcare professionals. And the reality is, if you look back not many years, we brought on board the urgent care or express care, and everyone balked at that. In fact, physicians balked at it because they thought, well, wait a minute, this isn't how I want to do it. I want a more holistic approach, and so on and so forth. The reality became that the driving force behind that was convenience and access, that you could get what you want, when you want it, and not have to wait. So, of course, this took off like wildfire for us. And from that, we began to get the idea, well, gee, what if we even offered access from home? If we allowed people to access their providers for a given problem, not something that required emergent care, but ongoing care, and we did it when it was convenient for them. They went through their day as per usual. They got a signal telling them their provider was ready. And then all of a sudden, like we are right now, they're face-to-face virtually. And what we found is that once people got used with the mechanics of engaging this sort of service, they liked it. They liked the fact that they could be anywhere. They could be out strolling and all of a sudden with their phone, sit down and conduct their visit. And I don't think it mattered what the age group was. Of course, my kids, this is the way they would do it by preference. But even our senior patients, when they got used to looking at how we get on board with this sort of information, it became very convenient for them. And pretty soon we found ourselves scheduling our visits this way. We found ourselves accessing laboratory orders and putting in our prescriptions, everything virtually. And it saves a lot of time. And I think what it really does at the end of the day is it enhances access for all of us, for the patient and for us, as for the providers as well. Of course, people say, now, wait a minute, I don't want to be on my computer and saying personal things and worrying about security. And of course, none of this would be possible without making it compatible with all of the HIPAA rules that govern how we share information within the medical community and with each other. All of this information, you still have to give permission to have it sent or going to another provider, what have you, just as if you were in the doctor's office. And in fact, when you sit down and think about it, here we are, we're going to have this conversation face to face. If I was in the office, I would be turning to the side, occasionally entering things on my computer. I like being able to see the patient the whole way through. I like having the entire encounter documented. I can go back and add whatever I need into the chart from the virtual visit as we go. So I think it gives us a record. It is very secure, no less secure than what we would do in our offices. And I think it's something that is comfortable for virtually anybody once they get started. My mom's 87. She's had a number of virtual visits, the first one guided by my sister, but after that, she's on her own. She didn't like the idea at first, but once she realized I'm not leaving home, I'm getting all the same information I need, and yes, I'll have to go somewhere and get laboratories drawn at some point. It was just very convenient for her, and I think it put her mind at ease. That kind of is in a nutshell, I think, where we're getting started. Adam, do you think you can comment on a few things, using telehealth and from a cost standpoint?
Sure, thanks, Tony. Yeah. So I would first, for the astute among you, you'll realize the background is moving in mine because I'm in a car. So this really has the showing our abilities to be able to at this time right now. We're in a room with guys.
We'll wait for a moment, Adam.
You're this conference together. Yeah.
Breaking up a little bit.
I'm breaking up. Okay. Is that better?
Yeah.
Okay. So rather than sitting in a conference with everybody, which we'd certainly rather be face to face, we make the best of this, and we can do things digitally and still be able to talk. Don't worry, I'm not driving. There's someone else, but I'm able to make the car to be able to talk to you all. So as we're singing the praises of telehealth here, where it's worth saying, well, how come we haven't been doing this all along? What were the barriers before? And certainly one of the bigger barriers was just change. And things where people want to be able to do things how they've always done them, and change. And COVID has told us all that we are much more adaptable to change than we have been before. This is something we've been working for before, but really accelerated our venture into telehealth. One of the other things that's changed is, not only are providers difficult with change, but our regulators have difficulty with change as well too. And so there was a fair amount of regulation around telehealth, things like who can perform the visits, whether they be physicians or nurse practitioners or PAs, where they have to be. There have been some regulations of having to be in the same state as the person to be able to do it, how those were reimbursed by insurance companies. And by necessity, all of these have been relaxed in a large part due to COVID, knowing that this is the only safe way for a fair amount of time to be able to see people. And while we're seeing people back face to face again, there's certainly a push of saying this is something we were able to do in relatively short time, that we were able to ramp up our telehealth presence. And in some cases, in a lot of cases, it's a better way to deliver care. And so we're being able to see that in a large part, a lot of those regulations were just too strict and they didn't make sense. And so there's a lot of advocacy around right now of decreasing some of those regulations that are around.
Adam, do you think that the fact that now there is a way that physicians can be more easily reimbursed, that has really made them support this in a greater way?
I think it has, and it's, if you look at the cost effectiveness of it, it's cost effective on many fronts. If you look from a physician standpoint, the cost effectiveness of this allows us to be able to be reimbursed for some services that were non-reimbursable before. So some of our phone messages that get a little more complicated, or electronic messages, we can just do a video visit, provide better care, faster care, and have it be a reimbursable visit. When you look from a patient standpoint, it's certainly maybe cost effective for them as well too, not only in as it's increasingly being covered by their insurance at the same as it would be for an office visit, but they no longer have to take the time that they might have to be able to be off work, to travel, to put the miles on their car. And then from a payer or an insurance company, it's looking more cost effective in many standpoints too. While the reimbursement they have may be the same in some cases, sometimes it's a little bit less. But if you look at the long haul for insurance companies and for payers and the total cost of healthcare, the increased access that we've been able to have has for perhaps better ways to be able to do some of our chronic disease management, to be able to communicate with patients better, see them more frequently, and keep them out of the emergency rooms in hospitals where really the high cost of care is. And we
What
found
about-
actually, yeah, go ahead, Tony.
Now, what do you think, how do you think the patient-physician relationship is affected? Do you think you can do this reasonably well or as well virtually as you may have in an office visit?
We really can. I think in being able to have bonding and relationship from it, certainly there's something to be said for sitting across from somebody and right there. But as you mentioned before, often a majority of the visit with someone with me in the office is either spent with my office staff, and not that the relationship with them is not important either, but if they're looking to be with me, that's checking in, walking to the office, getting roomed by the MA, is part of what could be their 15 or 20-minute office visit. A large chunk of the time is spent with that. Now, the majority, if not all of the time, is spent face-to-face with me. And, we'll be honest that computers in the office have been a barrier sometimes to being able to talk face-to-face with people. And so we're turning our head one way to document on the computer, to look in the monitor, and limiting our eye contact with patients. And it's something we work on, but it's just the reality of it. And now on the screen, the vast majority of time, we're really literally face-to-face with each other. It's also a new experience. Some people feel more open behind a monitor and are able to have at least a sense of security to be able to share things they might not have been able to share face-to-face. And I even have times where it's a different relationship with the patient. So I'm talking to a kid and they can show me around their house and show me their bedroom and show me some of their favorite things. And it's kind of cool to be able to see that and be able to have, in some ways, a deeper interaction with them and a better understanding of their home environment.
That's interesting. That's exactly what my mother, 87 years old, said. She said,
Yeah.
I didn't feel as flustered. I had some questions written down, and when I'm face-to-face, I'm all of a sudden in a much more anxious mode than sitting at home in a chair and getting to glance at her paperwork. What do you think about the thoroughness? I remember hearing when I was in medical school, they would say, if you just listen to the patient, they will give you the diagnosis. So what do you think about the accuracy of our ability to, sort things out with telehealth?
It still depends, and this is a learning skill for doctors because it's not something that we've been taught about. Certainly the vast majority of problems that people come with and the vast majority of our diagnostic thinking, our differential diagnosis, is done with the history. So that taking the time to really listen to the patient and hear what's going on, ask appropriate questions, and hear what's happening. And you'd be very surprised how much of a physical exam you can do over telehealth. I've gotten pretty good at being able to look inside people's throats, into eyes and noses, to be able to count breathing. There's some good data emerging now that having someone jump up and down is almost as good, if not as good, as pushing on the belly to see if they have something like appendicitis. I'll get up and have people mimic movements, and they say their arm hurts. Okay, well, move it like this and move it like that, and it can be interactive like that. Certainly, there are some things that are difficult to do. I can't look in a kid's ears over the phone yet, but there are peripherals on the market right now with home blood pressure monitoring, with attachments that can go to a phone, that can look in ears, that can look in eyes, that I think are going to become more commonplace as we do this. It's also interesting to note for things like rashes, where you think it'd be a natural fit for telehealth, we're seeing some limitations in the technology people have, and that the resolution on videos is not necessarily as good at pictures, but that a lot of the telehealth platforms that we're using right now have the ability to upload a still image. And so that can wind up in the medical chart of the patient, of having the image there so that you can refer to it later and get a better resolution of it to really study it, versus, say, trying to look at a rash on a moving 3-year-old. I can take some time and do that. So.
That's an excellent point. I for years have, when I see a suspicious looking mole, will take a picture of it and fire it right off to a dermatologist friend who may not give it a diagnosis or an appointment, but he will say, I need to see them right away or I've got weeks and that's going to be fine. Well, Adam, thank you very much. Deidre, I had a couple of questions I wanted to ask you. So when we look at implementing this, do you think there are legal barriers to where we're heading?
I think, most, when you look at telemedicine, most things that we're seeing are pretty low risk as far as, the malpractice aspect. So I don't feel that as far as like your carrier for your malpractice insurance, is that going to be a barrier? I don't think so, and I don't think it should be. I feel that the acuity that we're seeing is pretty low. And so the risk is also low with that.
Do you think that the services we're providing are really going to flourish only in rural areas, even like Worcester, or do you think in metropolitan areas this will work as well?
I mean, I think it's definitely both. I mean, there's in rural areas, I think we're seeking for telemedicine because they're lacking providers. So if you think about 20% of Americans live in rural America, and you only have about 1 out of 10 physicians practicing in rural America. And out of those physicians, you have about 40 specialists out of 100,000 people in that population. So, if you need to see a GYN oncologist, you might have to travel 300 miles if you live in the middle of Texas or Nebraska, wherever. So if you think about it that way, telehealth is really important in rural communities. And so I think bringing that, but also with urban communities, if you live in New York City or you live in Syracuse, you might not have, an hour and a half to go to an appointment by the time you catch a train, catch a taxi. So doing telehealth can save you a lot of time. I mean, time-wise in urban cities, yes. Rural areas, I think it's more of getting care to those people.
Do you think that patients are saying, I'm only going to do this for an urgent need, or do you see maybe our annual exam, if certain things aren't required in terms of physical examination, do you see this maybe becoming the way we just access our general practitioner for our annual visits?
Absolutely. And the way that I use telemedicine, most of it is for medication refills, discussing birth control options. We haven't as GYNs done like annual visits per se that way, but I do see it coming. I think that people are going to use this more as routine care, a follow-up for chronic conditions. So instead of an acute illness, which requires, medical attention immediately.
Okay. How about, do you see this as a stopgap measure, or do you see this as something that is actually going to grow in its capabilities, and that this may be the future in a way that we can deliver specialty care in particular to areas that would otherwise be very hard pressed to have them?
100%. I mean, this field is just starting. Yeah, it's been around for a long time as far as, if you look at some of the data, they're saying when we had pagers and, like Adam said, just answering a telephone call was telemedicine, but this is just the beginning. I've even seen, so for me, I'm in my OBGYN world, but, plugging in a little ultrasound on your iPhone and you can do an ultrasound right there. So these things are coming, like Adam said. I mean, there's so many new technologies, and this will be a huge factor in how we practice medicine over the next few years, for sure.
One of the things that we had begun a number of years ago was group visits. And for particularly certain chronic conditions, like say diabetes, where everyone has a common goal to lower their hemoglobin A1C, to have better control, there's an opportunity to meet as a group. And that means having to get a group together. We had to see each one of those patients individually. Then they had to all be in a common room. And there you were with people on either side of you, and you were having to talk about something that perhaps was very personal. Well, now we could do those visits at home, and someone may have a question that's very important to me, but I hadn't thought about it. And so we could even meet as groups and do group visits. I think there's an enormous potential surrounding this entire topic. And I'd be curious what questions, Dee, you might have, or Justin, you might have.
Justin?
Yeah, I actually do. so you're presenting to Rotary. The vast majority of our membership is older population, older in age. So it's probably pretty intimidating for them to think, I'm going to do a telehealth visit. Can you maybe walk through that process from a Cleveland clinic? I'm interested in it. How do I do my first telehealth visit?
So I can kind of take that a little bit. So
please.
it's kind of changed a little bit since the pandemic, just because of systems being overloaded. So the Cleveland Clinic has now changed, and we are over a Zoom platform, but on the MyChart. So through the Cleveland Clinic, you log into your MyChart account, and it's very easy. There's a little telehealth link, and Adam and Tony, correct me if I'm wrong, but you know, when I've done it, you go in, it's a telehealth link. And they basically hop into our waiting room, and on our end, on the physician's end, we can see when they enter our waiting room, and we literally click a button and we connect. So it's very easy. It's literally a two-step process for them. So once they're set up, it's very easy.
Do they already have to have Zoom on their phone or on their computer already?
They have to download the Zoom app.
Okay, gotcha.
But they don't have to launch a separate app. It's all within MyChart.
The MyChart,
And so if you can do MyChart, if you can do email, and if you've ever done a FaceTime or a Skype call with anybody, so I imagine a lot of the people we're talking to have grandchildren and may have done that, you can do a telehealth visit. There's really no difference between it.
So let me kind of ask, in my case, when I go to the doctor, he or she typically listens to my heart using a stethoscope. How would you be able to do that? Or in some cases, they'll like to look up openings in my body just to make sure that I don't have prostate cancer and stuff like that. I mean, these are things which I need to understand how you would do remotely.
So there are some things that we're just not going to be able to do without a face-to-face visit. So we can ask you all those 30 questions that you get asked by every person that you come into the office remotely. And if there's and we can certainly find out about your history. We can observe many things on the physical exam. But as it is right now, we're not doing an entire physical exam remotely because we can't. We can coach patients through it, but you know, I'll say from the medical standpoint, and certainly from the OBGYN standpoint from your colleagues, I think there are some, shall we say, sensitive exams we're not going to ask people to do themselves.
Yes. I will say though, just, you know, from an obstetrical standpoint, it's really nice. So, you know, OB, we see patients every 1 to 4 weeks, depending where they are in their pregnancy. So at our practice and at all Cleveland Clinic facilities, we are giving Dopplers to patients that are pregnant with blood pressure cuffs. So we are providing that. So we can do, so, you know, typically they see us around 8 weeks, but we will give them a Doppler between 20 to 28 weeks. We'll give them a Doppler and they'll listen to the heartbeat. They'll check their own blood pressure. They'll check their weight. And then when we meet with them via the MyChart Zoom, they have all of that information down so they can listen to their own baby's heartbeat. It's a great resource for these patients, you know, especially if they're coming from, you know, New Philadelphia. I have a patient that comes from Cincinnati. I have one from West Virginia that comes up. So, you know, it's a really nice resource for them to have.
And some of these modalities like blood pressure checks and even blood sugar, they can be conveyed remotely from the devices that the Cleveland Clinic uses, the Omron devices, these little wrist monitors. And it also might even give us a more accurate assessment because patients know for blood pressure, I've got to be seated for 5 minutes. My feet have to be flat on the floor. I shouldn't have had a caffeinated beverage or smoked within a certain period of time. And they also don't have that white coat hypertension. I'm in the doctor's office, I'm anxious and I'm nervous. And we may get actually a more accurate assessment in some cases. When Dee, you mentioned, you know, a rectal exam for prostate cancer. Well, if you took a really good history and you had enough time to look at enough bullet points, you might say, you know, we're going to get a blood test to look at this because physical examination is an art form. And it takes doing very large numbers. And I don't want to say we've fallen off the curve, but I certainly can't do what my predecessors did with a stethoscope. When I was in medical school, we listened to a gentleman who was just absolutely remarkable. And then they would do a echocardiogram and he would have already said everything that was there. Well, that's a rare individual. So I think there's ways that we can turn this one way or another and decide on what kind of testing people might need. Or it may be that, you know what, you have to come in for a physical exam because you've hit a few key markers.
A quick question. I know that primary care physicians, just the availability to your primary care physician can sometimes be an issue. And just the overall number of PCPs is low. So if I can't get to see my primary care physician, telehealth is an option for me to be, to have a visit with a doc who can see my chart. Is that correct?
Sure. Yeah, I think there's a couple of different platforms that we can run with that. Certainly, all the primary care doctors are doing telehealth visits right now too, where we've been expanding a model at Cleveland Clinic, both pre-COVID and now afterwards as well, of pairing both doctors with nurse practitioners and physician assistants in primary care to act as teams of primary care physicians in order to expand our access and have more bodies that can see people. But Express Care certainly sees a large number of patients here for our more urgent visits as well. Also, excitingly, for some chronic diseases, we're partnering with our specialists who haven't had traditionally the same kind of access or ongoing disease management, but say this could be a shared thing between a cardiologist to help manage someone's heart failure, that one time you see the primary care physician virtually and one time you see the cardiologist virtually, and be able just to expand the number of people that can care for you for your chronic diseases.
That's a good point. You know, another thing that's in the pipeline is they're looking at subspecialists, say ear, nose, and throat doctors, to partner with primary care so that real time during a virtual visit, someone says, you know, boy, I'm not so sure what the next step should be. Do I need an ENT referral, or can I give steroids for a period of time for something? They'll be able to contact that ENT doctor. There'll be a person designated, take the call real time immediately, and maybe prevent having to go for another visit at a higher cost because they just had a immediate consultation. So that's something that's just being looked at and just getting off the ground.
So I imagine that the market for devices, particularly miniaturized devices and devices that can communicate information to your doctor, is going to be huge because, like you said, you know, blood pressure can be communicated. And now I see this device advertised on television that gives you your EKG, and very quickly, you know, I think whether it's $99, $199, but that's amazing, and how small it is, and these will probably proliferate.
Yeah, there's no question about it. Not only are they inexpensive, but they're very accurate. There's a blood pressure monitor that the Cleveland Clinic uses. It goes on the wrist. It tells you when your arm is in the right position by the series of beeps that it has, takes your blood pressure. It also records it. So the important thing is that on the occasion when I do see my physician, which used to be 4 times a year for what I was going for, I now only see them once. And they just download the information off my blood pressure cuff. And I bring it with me so that when the nurse does take my blood pressure in the office, she compares what she got to what I then get immediately thereafter with my wrist monitor to know that it's accurate. And actually, it's my wrist monitor that's probably more reproducible than it is, because I think I have that white coat hypertension, truth be told, to a certain degree.
Sure.
I get wound up.
Business-wise, working at the chamber, we have heard businesses that are going to incentivize their employees to use telehealth from a percentage pickup of the bill. Do you see medical institutions giving better rates for telehealth to kind of promote that and to push the consumer that way?
Shall I take that one?
I can talk.
I think it's a, please, Adam, go ahead.
So, I think some of it is the rates at which things get billed are largely out of control of the institutions, and a lot of it, and rest with the payers and with CMS, the Center for Medicaid Services, that set the rates for lots of things. Right now, at least from a reimbursement point, it may be fairly equivalent to what's in an office visit, but if you think about the productivity time to the employer for someone doing a telehealth visit versus doing an office visit and the time that takes away, I think there's an advantage in that just alone. And I think that it is something where, for particular, depending on what it is, we may be more efficient in telehealth or less efficient in telehealth. And I think the efficiency in how we're able to handle a certain visit is largely going to drive the cost for that visit too.
Yeah, I think I can see down the road if a patient has an appointment set up, but they haven't seen the physician yet. And it's really not until you're making contact time that you're actually kind of on the clock monetarily. So could you imagine having a digital history that you're filling out that automatically, if there's something untoward that you've said or something that is of concern, it gets flagged. So a much larger history could be taken, digested, and save that portion of the visit. So from a time standpoint, you charge by complexity, but you also charge by time, depending on, which way it goes. So I think that in the future, as we modify this and grow this, I think there's the potential to reduce cost for time spent. And not to mention that you don't have a person checking you in, you don't have a person taking your vital signs, and you don't have a waiting room. I mean, the cost of doing business should improve as we fully embrace this. I mean, we're not there yet because it's an extra piece, but when it becomes a primary piece and going to the office is the exception, I think it's possible that, we could contain costs more effectively.
And I think we're seeing that. I mean, I've even had appointments at 7 o'clock at night, and she's doing it from the comfort of her own home. So I think you're absolutely right, Tony. We're not paying for that office space. We're not paying for the MAs and everybody else, the support staff. So.
Other questions?
Dee, do you have one? I've got another one if you do not.
Please, go ahead.
How is the last 5 months with COVID-19 and the people just scared to step foot into hospital, good or bad, right or wrong, how has that increased your the use of telehealth?
So I feel like for our standpoint, the first, March, April, May were really slow, and that's when we saw a huge spike in telehealth. I don't have the exact numbers in front of us as far as our office visits versus telehealth, but I can tell you that probably 80% of my patients I was doing telehealth. But recently that number has kind of switched back. My patients want to come back to the office, except for I have a lot of OB patients that want to do the virtual visits. They still want to do the telehealth. Some of my younger patients really liked it, so they stuck with it. But we definitely saw an upswing, and I think we're going to keep those numbers, but not as significant as what they were in March and April from our perspective. I don't know about you, Adam and Tony, what you guys feel.
Yeah, I think go ahead, John.
Go ahead. Well, we dropped almost 40% in visits, as COVID came upon us. And, the upswing has been consistent, but it's not like it goes right back to where it was. We still aren't there. And of course, there's also surgeries and so on and so forth. There still have a lot of concerns. And as we see this more recent spike, as we've more or less loosened the reins, we're looking at ways. But the healthcare environment itself is actually a very safe environment. the use of personal protective equipment by healthcare workers, and the number of people who are in a healthcare setting who actually contract COVID at work is relatively low. And perhaps even, I'd even go so far to say remarkably low. And so I think it's a safe place to go. I think we take every precaution, but I think we're trying to lean towards, serving individuals who need to be served in that setting and doing what we can virtually now. As I think Deidre pointed out, things I hadn't even heard of yet that I think are just fabulous, and Adam, you as well. But please add to that.
Yeah, sure. So I would say, certainly in the beginning of this, in March and April, almost we really turned on a dime and went from, despite trying to encourage people to do more virtual visits, we were maybe 1% virtual visits throughout primary care in the clinic, to doing greater than 90% virtual visits in those months. Since that time, it's gone back into, overall, we're probably closer to 70 to 80% back in person over the summertime, with that 20 to 30% virtual visits, just because of the deferred care that we had and those things that currently we're better doing in the office than we are at home. I would say I fully expect come fall and winter, when we're seeing more illness, to have that ratio go back towards more virtual visits, at least assessing someone virtually first before we bring them into the office, to help bolster the safety that we have, so that we can say, is this someone who really needs to be seen? Can we deal with them virtually at home? Do we not need to see them at all, or do they need a higher level of care? And I think, we may come to a time where we look back and say, what were we doing bringing all these sick people into the office to sit in the waiting room? Why didn't we always do virtual things to triage them? And certainly that's a scenario in the future that I can see happening.
Yeah, I've got that feeling, especially in pediatrics, where historically, my parents would have to round all three of us up. We all three go to the doctor's office because, you didn't get a babysitter back then. Now you're trying to bring only the sick person in. It's really, I think, has a remarkable impact, not to mention all the other things we're doing to, curtail spread of the virus, or any virus for that matter.
Yeah. Well, wonderful. I mean, I'm excited about where this industry is going, and in terms of how telehealth is being practiced. And I look forward to a lot more devices and using them and getting better care all the time. So I would like to thank each one of you, Tony, Adam, and Deidre, for taking the time out to do this for Rotary. We appreciate your insights very much, and look forward to kind of chatting with you from time to time again to see how things are moving along. So thank you very much.
Thanks for having us.
Thanks for having us.
Thanks for inviting us.
Bye now.
Bye.
Take care.